Yeah, so Harry de Koning presented the mortality results of the Nelson trial at the World Conference on Lung Cancer, which was in Toronto last September. And so these are his slides. It was, as usual, a collaborative effort. So the background is that the National Lung Cancer Screening Trial showed a 20% relative reduction in lung cancer mortality for annual screening over 3 years with low-dose CT scan versus chest X-ray. They recruited over 53,000 individuals at high risk for lung cancer, and about 60% of those individuals were male. In a post hoc analysis, they identified there might be a differential benefit by gender with a relative risk of 0.92 for men and 0.73 for women. And that's consistent with what we find in the natural history of lung cancer, where in general women do better than men, and so perhaps women might be even more advantaged by screening with CT scan. So other than the NLST, no other trials have shown a mortality improvement. So this is the Nelson trial. So this was a randomized controlled trial. They recruited individuals through population-based registries. They were randomized to CT screening versus nothing, so no chest X-ray, nothing. And they used different screening intervals as opposed to the NLST, which used annual screening, and I'll come to the details of that. And they looked at volume and volume doubling time of nodules rather than two-dimensional measurements. And there was central reading of CT images, so it wasn't just done by the local radiologist, there was central reading. And then they had an expert review committee for primary outcome, and they followed up on outcomes through national registries. And of course, the Europeans in general, and the Dutch particularly, and Belgians have these national registries which allow them to do some of this work. So the recruitment was by mail, and you may think that's sort of a trivial thing, but it turns out that it can be important how you try to recruit individuals. They were aiming at men 50 to 75. They sent them health status questionnaires, particularly addressing their smoking habits and any history of cancer or family history of cancer. They looked at their general health and lifestyle and estimated from this their lung cancer mortality risk. They then they considered individuals to be eligible if they were current smokers or former smokers who had quit less than within the last 10 years. And they considered the eligibility to be either 15 cigarettes a day for 25 or more years, or 10 cigarettes a day for 30 plus years. So just to compare these two, on the left-hand side of the screen is the Nelson trial, on the right-hand side is the NLST. Both were randomized. They used low-dose CT in the screening arm. The NLST used chest X-ray in the non-screened arm, and with the idea that all the previous chest X-ray trials looking at screening had used chest X-ray and found no benefit. So they felt that that was a reasonable control arm, whereas the Nelson trial didn't use nothing. So there were no chest X-rays in the control arm. Nelson used a volumetric analysis, where the NLST used a two-dimensional analysis. And there was a categorization of lung nodules in the Nelson. NLST, there was initially sort of no real categorization, but the lung Rads algorithm grew out of the NLST results. The NLST used screening annually. The Nelson trial used an annual screen year 1 and year 2, and then there was year 4 and year 6, and the follow-up in Nelson was 10 years as opposed to 6 years in the NLST. And this is just the schema, which is a bit obviously hard to read. So they had this recruitment step 1, where they mailed out a general health questionnaire to a population of 600 and some thousand individuals. They had 150 questionnaires returned, completed 148. So this is just in terms of if you're recruiting for a screening study, you can reach a wide range of participants with a mail-out, but your return on investment is relatively low. They then mailed out a second questionnaire, including an information brochure, an invitation to participate, so are you interested, and an informed consent form. So if you wanted to participate, you mailed back and said, yes, I want to participate, and here's my consent. And out of that, they got 30,000 eligible individuals. And again, the inclusion criteria were age 50 to 74, smoking history, and if they'd quit less than 10 years of quit. They excluded people who had moderate or poor self-reported health, who are unable to climb 2 flights of stairs, who are morbidly obese, who had a lung cancer diagnosis, and a current or past history of renal cell, breast cancer, or melanoma, or if they'd had a chest CT within a year. So they randomized 1-to-1 those people who signed their informed consent, so they had 15,822 people, and ultimately they randomized 15,792, so as compared to over 53,000 in the NLST. So the screen arm had 7,900 individuals. They had a year 1 screen with about 96% uptake, a year 2 screen, again about 92% uptake. They then had a 2-year gap to year 4, a little drop in retention to 88%. And then they had another 2.5-year gap before the last screen, and again, a bigger drop in retention, so 67%. So recruitment is important, uptake is important, and retention is important. So you can see that they had a significant drop-off. And the usual care was no screening. And they have these advantages, these national linkages with Statistics Netherlands and Belgium, the Dutch-Belgium Cancer Registry, and they have a Center for Genealogy, and they had a cause of death review. So I'm just going to focus on the lung cancer detection rate, which was about 1% for each round. So in round 3 it was 1.1%, and there is a total detection rate of 0.9%. And the positive predictive value of a positive test result, the CT, was 41%. So, you know, it's not perfect. So this is the graph showing the cumulative absolute number of first lung cancers. So you can see the blue line is the control. So I don't know how they found those out, but they found them. And of course, there were more cancers detected in the CT arm. So then they look at a thing called stage shift. So the idea is that in most jurisdictions, 2/3 to 3/4 of people who are diagnosed with lung cancer are found to have early or late stage disease, stage 3 or 4 at the time of the diagnosis. And the idea with screening is obviously to identify them at an early stage. So in this orangey color, red color is the Dutch cohort, and that's based on their own cancer statistics, so what happens in the usual population. In green is the control arm, and in blue is the screen arm. And you can clearly see that in the screening arm, you detect more early lung cancers, 50%, as opposed to less than 10% either in the control arm or in their usual population cancer registry. As opposed to the stage 3 and 4, so 3 is pretty evenly distributed across screening, the control arm, and the population registry. But you can see the stage 4 patients much lower in the screened arm, which is what we want and what we expected. But you can see that normally most people who are identified with lung cancer are identified with advanced stage disease. So what about the deaths? So again, the screened arm had lower lung cancer deaths, so 157 lung cancer deaths, this is men, in the screen arm versus 214 in the control arm. And the lung cancer mortality ratio for males at year 10, which was their outcome, was 0.74, and you can see the confidence intervals does not cross 1. So a 26% reduction in lung cancer mortality at 10 years for men. But look at what happened with the women. It is even a more significant reduction, almost 40% reduction in lung cancer mortality for women who participated in this screening study. Now, it was aimed at men, but about 16% of the population actually screened were women. So a huge benefit, even greater than the NLST, which I think speaks to that there was nothing in the non-screened arm. There was no chest X-ray, nothing. So the Nelson trial had 4 CT scans at different intervals. The compliance rate overall was 86%, which is good, but you could see that over time it dropped off, so retention is an issue. They screened high-risk individuals, and they demonstrated a reduced risk of dying from lung cancer, so a mortality reduction, which is the gold standard for screening studies. And for men, it was a 26% reduction in lung cancer mortality compared to the control arm. And for women, it was consistently more favorable, between 39 and 61%. So issues in lung cancer, and this is just sort of my editorialization on it. Issues in lung cancer screening. I run the lung cancer screening pilot for Cancer Care Ontario, which is a provincial program. We started it some years ago, and we have currently, we just added our 4th pilot site. The goal for us is to develop population-based screening across the province, so as opposed to each individual hospital doing their own thing, we're trying to develop a population-based program, so I'm kind of in charge of that. So our issues are recruitment. How do you get the right people in? What are your eligibility criteria? Do you use the NLST criteria? Do you use something else? The low-dose CT. Everybody thinks, well, every radiologist can read a low-dose CT, but we found out that wasn't actually true. We developed a little testing module for the participating radiologists, and our radiology lead, Heidi Schmidt, developed, I think, 20 cases and sent them out to all the radiologists who were going to participate in the pilot. And they had to score them according to the lung Rads algorithm. And it was surprisingly discrepant across the group. So just because you've got a fantastic chest radiologist doesn't necessarily mean they're consistent when it comes to lung cancer screenings. We used a nodule management algorithm. So in the original NLST, there was no nodule management algorithm. It was, they found a nodule, they told the referring doctor, and the patient went back. So we use the lung Rads nodule management algorithm, which is designed to get the people with really suspicious lesions off to get their treatment, and people who just have the sort of more innocent nodules are followed. Interesting, some data that came out of Nelson was, if you look at ground glass opacities or ground glass nodules, over half of those disappear on the follow-up scan. So we shouldn't be operating on those individuals based on one scan. The screening interval is important, and I don't show this data, and they didn't show it at the World Lung Cancer Conference, but the big question is, do we have to screen everybody every year? And the answer is yes. What happened in Nelson was the 2-year gap and the 2.5-year gap accounted for some of the more advanced cancers that they reported. So it seems that if you're at high risk, you need annual screening. Retention is an issue. Some people think they come and have a CT scan and they don't have any nodules, they're fine. That's not the case. They need to continue to come back for screening, just the same way as women come back for repeat mammography, or people come back for repeat colonoscopy, or whatever it is. You have to come back if you're in that high-risk group. And lastly, the management of suspicious nodules. We want people with lung cancer to get managed expeditiously, and we don't want to be taking out a lot of benign nodules. This is just our pilot design. So we have this, we use a provider and public recruitment strategy. We actually linked with our primary care folks to, did a lot of CME with our primary care, had lots of conferences about who to recruit. And we just gave them kind of some guidelines. So we used age 55 to 75 and a smoking history of more than 20 pack years, not necessarily continuously. And so they can refer those individuals to our screening program. We then use the eligibility criteria according to it's called the PLCO risk prediction model. Martin Amagi, who's our scientific lead, developed that risk prediction model. And so we chose to use a greater than or equal to 2% risk, which means that individual has a greater than or 2% or greater risk of developing lung cancer in the next 6 years. And that was developed by Martin. We have end-to-end navigation, so we have a navigator start at the recruitment phase and they follow them all the way through. We have the radiology QA, which I mentioned, which is our radiologists who participate, do this little program, make sure everybody's on the same boat. We also have a policy that all the positive scans are double read for the first 15 positive scans of any one radiologist. Because what we found was that people new to this tend to overcall what we call the 4As. And the risk of cancer in the 4A group is about 5 to 15%, and they tend to overcall that. Then we use the lung rads, as I mentioned. Initially, we had a same visit result within 90 minutes. I got that idea from Betty Tong, who's here somewhere. That was a great idea, but it turned out not to be very feasible, and our radiologists hated it. So now we give them results within 2 weeks. And then we have these diagnostic assessment programs, which are basically designed to, somebody with a suspicious lung nodule gets referred in, they get worked up, they get treated. Embedded in this is a smoking cessation program. And I don't know if Matthew Steliga is here, but I got this idea from Matt, that anytime an individual interacts with the screening program, if they are a current smoker, we do a smoking cessation intervention with them. We don't ask if they want it. If they say they don't want it, we don't do it. But basically, we do that every time a smoker comes in. If they turn out not to be eligible for our program, we refer them to another smoking cessation program. But basically, we've used an opt-out model. And the uptake is actually fantastic. Over 90% of the individuals accept that referral to the smoking cessation program, and our navigators do an initial ask or initial intervention. We don't know yet if that's going to translate into quits. We'll know that at the final evaluation, which will be in another year. Oops. And I just wanted to show you this because Doug Wood was kind of on my case about this. So what is the difference between the Amagi risk prediction model and the NLST model? And so the NLST asks about age, smoking status, and then this component, which is the hard part. Age of smoking initiation, number of years elapsed since quitting, length of in-between quit periods, and the average number of cigarettes smoked daily. The Amagi model asks a few more questions, asks for height and weight, and then that calculates a body mass index. People with low body mass index have higher risk of lung cancer. They ask about level of education. You might think people were sensitive about this, but they weren't. Lower levels of education is associated with a higher risk of lung cancer. Personal history of COPD. So we didn't ask them to do a pulmonary function test, but we just asked, have you ever been told you have emphysema, or have you ever been told you have COPD? A personal history of any cancer. Obviously, if they're lung cancer, they're not eligible, but a personal history of any cancer. And a family history of lung cancer. And this turns out to be actually quite important. And in Taiwan, they're actually starting to screen people with a family history of lung cancer because of this phenomenon of seeing all these women who are lifelong non-smokers showing up with lung cancer. And it turns out a lot of them have a positive family history. So it turns out that most of these questions are quite easy to answer. So they don't add a lot to the time taken, and the navigator goes through this with the individual. But this risk calculator is online, free, available, so it's easy to access. This turns out to be the hardest question to get the accurate information. And it's required for both. So the hardest part is actually in the NLST as well. And I'll just show you, this is some early data. We've recruited almost 3,000, well now it's over 3,000. Most of them were provider referred, so their family doctor referred them in. We've completed a bunch of risk assessments, and of those risk assessed, 66% were eligible. So a very high rate of eligibility compared to, for example, the NLST or the PLCO study, where we estimate about a third of the people referred will actually be eligible for screening. So this kind of shows us that the family doctors were good at referring appropriate individuals, and that was actually identified also in the VA study. So the primary care was important. In terms of smoking cessation, 65% of the eligible individuals were current smokers, and 80% of those individuals accepted the in-hospital smoking cessation services. So the usual rate is about 20%. So if you use an opt-in model, like we ask them, do you want to be referred to smoking cessation, it's about 20%. If you tell them, we're going to refer you to smoking cessation, it's about 80%. So I would recommend, if you're starting a screening program or you're running a screening program, you might want to consider that, because I think the health benefits of smoking cessation are going to probably be as good or better than the screening itself. Thank you very much.